welcome everybody. My name's Deshani. I'm one of the fellows, I'm the Echo Fellow at Nepean this year, and today I'll be talking about ventricular septal defects. Okay, to close that. So what is a VSD? So a VSD is generally a congenital lesion that is a communication between the left and the right ventricles. So it usually takes up about 20 to 25% of all congenital heart lesions. In terms of its underlying pathophysiology, the blood is usually shunted from left to right, so the left ventricle to the right ventricle. And as a result of this, there's increased blood volume delivered to the lungs and therefore increased venous return to the left side of the heart. And then over time, if there's a significant left to right shunt, this then causes dilatation of the left heart chambers. And then like longer term, you can then develop pulmonary hypertension, and then subsequent right heart dilatation may develop, but this is a very late sign. In terms of ways that you can classify VSDs, so by like cause or type, so there are generally congenital, and there are 4 types of VSDs that fall under the congenital category. And then you have acquired VSDs, and these are more that occur in the adult population. So we may see these, they're not very common, but they might occur. So I guess the major ones would be the post-myocardial infarction intraventricular septal rupture, which can cause a VSD that way, a surgical complication from a transcatheter aortic valve replacement, or a septal myomectomy or infective endocarditis are the other sort of potential sources of acquired VSDs. With regards to the congenital VSDs, I find that like understanding where how the intraventricular septum is developed, or from an embryological standpoint, can help, I guess, functionally delineate what VSDs are what and their location. So on the right, I'm not sure if you can see my mouse, on the right, on the left, sorry, on the left side of the screen, you can see this is a primitive heart. So this is around week 7, I think, is when this the heart looks like this. And there are some sort of primitive muscle or like areas of embryological origins from which the ventricle arises from. So you've got your the muscular interventricular septum, the membranous interventricular septum, which comes from, I think, endocardial, the endocardial cushion, and then the conal septum. So what these eventually become, so the muscular interventricular septum, as it develops over time, becomes like the muscular IVS in the fully developed heart, and that then can be divided into the inlet, the trabecular, or the outlet. So the inlet is what separates the tricuspid and the mitral valves and extends to the distal chordae attachment of the tricuspid valve. The trabecular is the largest part of the muscular interventricular septum and extends from the inlet to the outlet. And then the outlet is essentially the remainder of the interventricular septum, and it's what separates the right and left ventricular outflow tracts and extends to the pulmonary valves. The membranous interventricular septum just sort of sits at the, it's located at the base of the inlet and the outlet components. And then finally, the conal septum is what ends up becoming the closure between the aortic and pulmonary valves, which you can see there. So VSDs form when there is errors in the septation or the formation of these various different components of the interventricular septum. So and the problem with this is that there's a lot of different terminology attached to the different types of VSDs. They all, I guess, in some way or another mean the same thing, but depending on which resource you look at, the names are going to be different. So some will have like a surgical relevance, some will be more derived from their embryological origin, some will be functional. So I'll be focusing on sort of the functional and anatomical terminology, because that's just easier for me to remember. So first is your perimembranous. So this comes from the membranous part of the interventricular septum. So when there's valvular septate there, that's when this one forms. Then you've got your muscular defects. So these are from the muscular part of the interventricular septum, and same way as there are different components of it, they've got VSDs associated with each part. So a VSD associated with the inlet, the main muscular component, and the outlet or the outflow tract. So I'll just go into those in a little bit more detail. So perimembranous is the first one I'll talk about, because everything else sort of follows a nice order, but the names themselves, like I said, again, they are sort of in my head a little bit out of order, but perimembranous is the most common kind of VSD. It makes up about 80% of all VSDs that patients usually present with, and these ones tend to are more common to close spontaneously over time. In terms of how they're otherwise known as a membranous, infracrystal, perimembranous, conoventricular, or like a generic type 2 VSD. These are located beneath the aortic valve and bordering the septal tricuspid valve leaflet. As a result of their proximity to the semilunar valves, it can cause a degree of aortic regurgitation as well. So if the AV cusps of the aortic valve kind of gets sucked into the ventricular septal defect, then you can get poor coaptation of the aortic valve and therefore regurgitation associated with that. Things that you might also see on echo associated with this particular type of lesion is a double chambered RV. So there's a hypertrophy of the muscle bundle between the inlet and the outlet of the RV, and that can cause like some right ventricular mid-cavity obstruction. And then these are also can be part of the GERBODE effect, which I'll talk a bit later, but this is when there's a left ventricular to the right atrial shunt. So these can be part of that sort of complex of lesions. Next is the inlet inflow tract. So this is one of the muscular VSDs. So it's also known as a type 3, annoyingly. It's also as an atrioventricular canal defect. So these make up 5% of VSDs in total. These are located just below the tricuspid valve and the mitral valve. They are very common in patients who have Down syndrome. This is not likely to be something that occurs in isolation. There usually is a tricuspid valve problem associated with these kind of VSDs. So you do, when you have a look at the, when you look under with the echo probe, you need to make sure you interrogate the tricuspid valve attachments as best as you can, because they often are involved. Like they sometimes can adhere to the VSD and they can kind of prolapse into the VSD. So they're the things that you might have to be mindful of when you're evaluating them. Next is the muscular. So this is the big chunk of the interventricular septum. It's also known as the type 4. This is the most common that occur in infancy, and these also can close quite without any intervention. They make up 20% of the VSDs. And I know like the percentages don't add up. This is all from Benita's book, so we run out of percentages. But anyway, this can be located anywhere along the trabecular surface. So you can have anterior, mid-muscular, apical, and posterior ones, and they can also be multiple that can coalesce and then become a single, come out a single orifice on the left ventricular side. Yeah. And then finally is your outlet or conus defects. So these are also known, like I said before, like it has many names, and some of them are like sort of anatomically derived, so subpulmonary, so it's just below the pulmonary valve, infundibular, which is another sort of name for the outflow tract, coral, and subcrystal, supracrystal. So these are, so I think, more embryological origins. doubly committed dural arterial VSD. I'm not really sure what that refers to, but oh, we've got another person. Oh, come back in. And so these ones generally, generally located beneath the semilunar valve, so beneath the pulmonary and the aortic valve. These are about 5% of the VSDs. These ones don't tend to close on their own. They're often commonly associated with other complex congenital heart diseases like tetralogy of Fallot, PDA, coarctation of the aorta, just to name a few. I'm sure there are multiple more. And again, same as the perimembranous valves, these can also be associated with, sorry, another one. Ben. Hi, Ben. Oh, it's slow to join. So like the perimembranous ones, these might be associated with aortic regurgitation because of the AV cusp coming into, welcome Ben, coming into the defect. And these are usually, as you can see, best seen underneath the pulmonary valve in the parastomal short axis view. So in terms of the role of echo in evaluating VSDs, so use it to find the type of defect, or I guess like where the defect is tells you the type of defect, the anatomical size of the defect, the direction of the shunt, the hemodynamic significance of the shunt, estimating the right systolic pressure, and also associated anatomical features to suggest either valvular involvement or other complex congenital heart disease. So in terms of where and the type of VSD that you might be interrogating, this can be identified on, so very specifically, you can find the different VSDs from the different views, and the different views can help differentiate which VSD it is. And like this, I've obviously not mastered this after looking at this, but I think something that I've noticed looking at some of the pictures is that being mindful of what the adjacent structures are and knowing where the different types of VSDs occur in the interventricular septum can help, even if you can't remember this picture from memory, that sort of helps differentiate the different types of VSDs. And please, if you have any questions, feel free to unmute and ask away. I'll try and answer as best as I can.
Hi, Des. Yes, sorry, it's Sam here. Can I just ask a really quick question?
Yeah.
Yeah. So do you sometimes, I sometimes find it's not quite as tricky. Oh, sorry, it's not quite as straightforward as sometimes this image makes it out to be. No. Sometimes, I guess. And I guess is your recommendation just obviously trying to do this from multiple different angles?
Oh yeah, absolutely. So like I don't think you can't pick a because like as you can see here, like the outlet and the perimembranous VSDs, they can occupy a similar space, but you need to interrogate multiple different views to help differentiate which VSD is which. And like it does in the same way as, you know, regional changes can tell you the lesion of the culprit lesion in someone who's come in with cardiogenic shock. So I feel like the different views can give you different perspectives of the different anatomical components of the interventricular septum, and therefore can help differentiate like the causes, the underlying type of VSD. I guess the other thing that you will probably end up needing to do is a tow that will also help delineate the nature of the VSD. And the advantage with tow is that you can do 3D imaging as well, and that can help just really interrogate that septal defect with a lot more detail.
Yeah, thanks, Tash. It's great, and it's sometimes not quite as straightforward as ASDs, where it seems to always be a secundum, but or most of the time,
Yeah.
it's unfortunately not the same thing.
I mean, if you want to go with your odds, and you're pretty saying perimembranous, but you still need to, I guess, go through all the views and go through not the motions, but you want to really make sure that you've got the right
differentiation, I guess.
Yeah. Sorry, I'm just admitting people into the room.
Oh, sorry.
No, that's all right.
Anyway, thanks very, very much. Cheers.
Two different, so bad at multitasking. Okay, so like I said before, as well as identifying the type of VSD, you want to know what direction VSD is going. So this is where color flow imaging comes into play. It tells you, it can tell you in which phase of the cardiac cycle the blood flow is going. So if you follow the BART, so blue away, red towards, so you can use that and following where the cycle is, where the heartbeat, where the shunt is occurring or direction of flow is occurring during the cardiac cycle, you can figure out it's still.
I find it so hard. I mean, just as Sam was saying, I find it so hard to really nut this down. I think you do need lots of views and from multiple different angles. And this view in particular, I always have to question myself whether it's above or below the aortic valve. Depending on the position, sometimes it can look like a ruptured, sinus valve or something like that. It's actually above the valve and it's not a real VSD. It's just, I think it's very tricky sometimes.
Yeah, it's not. I mean, me personally, I've not seen a lot of VSD, so I don't have a lot of experience to call on, but just looking at the pictures, I was getting confused. Well, I had to think hard about which one is which, and I don't think you're going to get it 100% accurate in the from a single transthoracic echo. I think you have to do more imaging to really know for sure where it is, I think. But the main, I guess, what you really want to know is how significant the shunt is, and does this patient need urgent management or not for it. So this is just a video of, play that again, of a shunt, which I think was reported as a perimembranous VSD. So what you want to know, what you want to see is that normally it should be left to right. So from the left side of the heart to the right side of the heart. And you want to know if it's during systole, or if it's also during diastole as well. So generally the left side of the heart, left side of pressure should be higher than the right side of pressure. So it should be going through left to right throughout. If you start seeing in someone who's got Eisenmenger's syndrome, which is where they've got pulmonary hypertension and now more right side of pressures are much greater than the left side of pressures, then these are when the shunt direction can either become bidirectional or reverse. So you'll see it going the other way. In terms of anatomical size, again, you can measure this or appreciate this in greater detail on with colour flow imaging. So colour flow imaging will help you at least identify where the VSD is. It's not always very obvious on 2D imaging and to appreciate the size of the VSD, because as you can imagine, you need to be sort of really well aligned with the actual defect to get, I guess, a more accurate size. And I think little traps to be aware of is that with perimembranous and I think the outlet VSD, the aortic valve root or cusp can get sucked into the, these are all pictures here. They can get sucked into the VSD defect, and so they can be a bit harder to detect. In terms of how you classify the size, so there's usually small, restrictive, moderate, or large, and I'll go into later in terms of what their clinical implications are. And then next you can figure out what the hemodynamic significance of the shunt is. So the basically you can use, I think the same way that you would with an ASD, you can estimate what the shunt ratio is. So you're comparing the pulmonary flow to the systemic flow, and you use the RVOT stroke volume. You calculate that and you compare it to the LVOT stroke volume. And if you get a ratio greater than 1.5 to 1, that's usually the cutoff for a hemodynamically significant shunt. The problem with this method is that there are a lot of limitations. So like every, I guess, measurement that you do with echo and Doppler, there's going to be a degree of error. And for in terms of estimating the stroke volume, estimating like getting the right VTI measurement and the error associated with the VTI measurement, like these can be additive and then they can sort of snowball and you're not actually getting a reasonable and accurate number. So I don't know, like again, I haven't seen many VSDs, but like I think it would be challenging to get a reasonable accurate idea from the shunt ratio whether or not a shunt is hemodynamically significant, but it is something that you can consider doing. And then next is estimating the right systolic ventricular pressure. So this is important for estimating the severity of a VSD, because when you start seeing features of primary hypertension because of volume overload or pressure overload, this then impacts like the need for, I guess, treatment, or like there is a prognostic issue as well. So you can estimate the RV systolic pressure from the TR velocity like you do normally, or you can estimate it using the peak VSD velocity. So this then tells you the difference between the right and the left, like the pressure gradient across it. So you know if there's if it's like small and there's a large gradient, then the left side of pressures are much greater than the left side of pressure is greater than the right. That's, I guess, more reassuring than if it was low gradients and there's sort of equalization of pressure, or if it's the other way around. You can estimate the velocity. You can estimate the RV systolic pressure using the VSD velocity and the systolic blood pressure. That was a bit more advanced than I was, and I think a bit of a hole that I didn't really have time to go into. So, but that is something that you can do. And in the absence of the RV outflow tract obstruction or pulmonary stenosis, the pulmonary artery systolic pressure is about equivocal to the RVSP. So these are all things that you can use to determine if there's any pulmonary hypertension associated with this. And I guess it also impacts on the patient. And then finally, I'll talk a little bit about the GERBODE effect. So this is a specific sort of AV septal defect, which is a left ventricle to right atrial shunt. This can occur with, I think, the perimembranous and the outlet VSDs. They can be congenital and they can be acquired. Acquired usually because of infective endocarditis of a VSD causing erosion and therefore sort of broadening of that VSD into not just a VSD but a ventricular to atrial defect, trauma, acute myocardial infarction or AV valve replacement. So again, this can be detected on echo and color flow imaging, but I guess one of the pitfalls and the traps is that it can be mistaken for the TR jet. And so and as you can imagine, it's going to be a really high gradient from the left ventricle to the right atrium. So this can then give you abnormally high peak pressure, peak velocities, and therefore pressures. So this is just a picture, a color image of what that looks like. So that's something else to be mindful of. In terms of how these people sort of present, so it really depends on the direction of the shunt and the severity, which is again determined by the size of the defect. So a VSD, and like generally VSD is associated with more than one abnormality, is considered moderate complexity. Anyone with a VSD and Eisenmenger syndrome, so that's the complex given by a right to left shunt, cyanosis and pulmonary hypertension, is definitely a complex congenital heart defect. So I think I would be calling for help in these kinds of people. And again, like this, the different size VSDs can have different sort of symptomatology or like severity of presentation. So you have your small restrictive VSDs, and this is when the shunt ratio is usually less than 1.5 to 1. The size in general is less than 25% of the aortic annulus diameter, and these ones are usually asymptomatic and they just need follow-up in the community and serial echocardiograms, and not much really needs to be done about them. The moderate restrictive, these are when they've got a shunt ratio of between 1.5 to 2, and their size is between 25 and 75% of the aortic annulus diameter. And again, these are generally asymptomatic and similar to the small restrictive. They don't really need to have any intervention. There's usually the large non-restrictive VSDs is when we need to start paying attention. So they have like the shunt ratio of greater than 2 to 1. So the RV, the pulmonary flow, is twice as big as the systemic. The size is greater than 75% of the aortic annulus diameter. So in me, that means that I think, blood will go down the path of least resistance, and the right side of the heart is definitely a low resistance system in general. And so this may mean that it will preferentially go down through the VSD rather than the outflow tract. So this is when they start becoming hemodynamically significant. In terms of how they look, so if it's early, then they usually just have features of LV overload and heart failure. If it's progressive, then they just start developing pulmonary hypertension, and the left to right shunt is less significant and less obvious, I guess. And then in sort of late or chronic issues, then you develop Eisenmenger syndrome. So that's when you develop primary hypertension, elevated right-sided pressures, which become suprasystemic, which leads to a right to left shunt. And then these patients, you see hypoxia and cyanosis. In terms of management, congenital VSDs, they get closed if they've got a hemodynamically significant shunt and don't have pulmonary hypertension, or if they don't have an indication for a VSD, but for a VSD closure, but they have significant aortic regurgitation, then these patients generally need to have some kind of closure device placed in. For secondary or acquired VSDs, so these might be the ones that we see in the unit, or we might see adult patients with progressively large VSDs. These also require closure. It varies depending on the etiology of the acquired VSD, but for post myocardial infarction, the timing remains really controversial. Like ideally they try and wait, but sometimes given the patient's hemodynamics, that's not always possible. And I guess for us, for critical care physicians, in terms of temporizing them until as a bridge to that therapy, usually vasopressors, inotropes, and mechanical support. So that might range from intra-aortic balloon pump, to ECMO. So that's the talky bit of my presentation. So I've just got some pictures that if you guys are happy to, we can talk through and sort of see which VSD is which. And then the pro can help me out here. Just Emma's joined us now. All right, let's see how we go. All right, who's still on the thing? Benny, do you want to have a crack? See what you think is this VSD? There's probably not enough pictures, but I couldn't find.
Okay, so I can see the aortic valve in each view along with the VSD, and the VSD is right below it. And that's both in your parasternal long and your short axis at the level of the AV. And it's quite, it's not, my short axis is not quite under the pulmonary valve, but it is, you know, there is some relation to the aortic valve. So I'm going to say membranous. Is this a membranous VSD?
Yeah, I'm pretty sure you're right on the money. Yeah, so the intermediate sort of looks like it's closer to also the tricuspid valve as well, maybe with the eye of faith. But yeah, but if you look at this little key on the left of the screen, you can see there's so that's the membranous. The yellow is the membranous, where the location of the membranous VSD is, and like Benny said, like it's right beneath, it's in very close proximity to the aortic valve in both the short parasternal long and short axis view, and probably a little bit closer to the tricuspid valve. So yeah, absolutely, it is perimembranous VSD. What do you think about the size of the VSD? A bit hard to really appreciate, I guess, but.
Oh, that's a bit difficult. I mean, it's probably not super small, but it's not super large. So can I just sit in the middle? The mid-size. I don't know. Mid-size. I don't know.
Yeah.
I think the middle category you're talking about, maybe, without actually measuring.
Well, this is from like a website that so I didn't actually take, so I haven't actually measured it myself, but it looks to me like maybe it's a moderate VSD, and it's probably a left to right sort of direction of the shunt. You'd have to slow it down, so that's all very hard to say on these pictures alone. Cool, alrighty.
It's interesting that there's no left heart chamber dilatation. So if there was a large enough shunt, you'd expect with a VSD left heart dilatation. And there isn't any of that. That might be, I don't know.
Maybe something more acute, or?
Well, it'd be an unusual location for an acute one, unless it was from something like endocarditis or something like that.
Yeah. Anyway, you nailed the location or the type of it. Alrighty, here's another one. And I'll be nice and I'll bring the little key up so you can have a little look. Emma, do you want to?
I've just got it up. Yeah, I always need to remind myself. It looks like an inlet VSD, maybe.
And why is that?
It's just like distal to the, the AV sort of groove.
Yeah. And same, like this, I think is a toe view of that sort of same kind of VSD, but yes, it is an inlet VSD. Alrighty. Ooh, yeah. Sam, are you still there? No, he's not. Ben, welcome. I know that you.
I'm in the car, so I'm audio only.
Oh,
so,
okay. No.
I don't want to run into a truck.
Using that excuse, Ben.
Oh, I'm in the car. I don't have great reception. Yeah.
Reception is okay. I can't do more than one thing at once generally.
All good. I don't want you to do anything you can't not comfortable doing. That's fine. All right. Well, maybe Benny, if you're happy, to have another go at looking at the VSD. Where is it?
Me again.
There's only 3 people. Ben's he's like, I'm driving. I can't.
Oh yeah. I'm driving too. Yeah.
I'm going to remember all of this conversation in one day.
All right, I can have a crack. So on the parasternal view, it is looking like it's very much going through a muscular area. And then on the short axis, Yeah, same. So we're kind of low down. We're like at the mid-level of the LV, right? So it's not under or related to any of the valves.
Yeah.
And then on this upside down, horrible.
Yeah, some pictures were weird.
Yeah. I would again. Oh man. So again, so this is full chamber view, right? And it looks like even though the sector width is it's upside down, right? I'm not imagining that.
No, it's a pediatric. I didn't realize this at the time.
Yeah. So pediatric, yeah. Again, so it's sort of like mid-level of the LV. So I would put my money on a muscular VSD, the trabecular kind of area. So not inlet, not outlet, not membranous, the other one.
Yeah. Process of exclusion. Yeah, perfect. Yeah, it is a it is a muscular VSD. Well done.
Is that from the same patient, Desh? The one where they've got D-shaped septum, signs of pulmonary hypertension.
I don't know. I'm just trying. I think they were all part of the. Yeah, I think so. Actually, yeah.
You might expect that, like with a prolonged VSD, right? When they get pulmonary vascular remodeling pulmonary hypertension.
Yeah. Cool. Alrighty. Got maybe a few more. All right, Emma, you're up.
Oh dear. I think it's one of the other ones that hasn't been mentioned yet.
Damn
the
it,
subarterial one.
Yeah.
Because when it's next to the pulmonary valve and it's just past 12 o'clock, that's how I divide up the subarterial.
Okay.
So the clock phase.
Yeah.
So if it's less than 12 o'clock, perimembranous probably, and more than 12 o'clock, subarterial.
Yeah. Okay.
Simple.
Me, I was like close to the pulmonary valve or close to the tricuspid. The same similar sort of thing. Yeah. Again, this is all just from looking at these pictures. But I'm pretty sure it's one of the oh no, sorry, that's the wrong one. Is that right? Yeah, outlet. Yeah.
It's the same. You can either call it subarterial outlet.
Oh yeah, that's right. Yeah. See, I still get confused by the different names that all these VSDs have. All right. So what's happening here? I'll open this to the group. Unfortunately, there's no color component. There's no color, equivalent.
Is it a sinus of Walisundara?
Don't remember that being on the little caption that came with this video, but I think the point of this is mostly to see that the right coronary cusp is covering or occluding the VSD, and there does seem to be an aneurysm sort of overlying it as well. So these you have to, I guess, when you do the color, it may be the color flow imaging may not be as impressive because the right coronary cusp is sort of occluding the defect, but you might also see aortic regurgitation associated with this. Would have been nice to have a color one, but I couldn't find one. All right, what's happening here? So this is, I think, an apical 4 chamber view. Maybe in that, or
is it a good one?
No, I think that's left. This is right ventricle. So this person had a heart attack a week ago.
Okay. So ischemic VSD.
Yeah, so interventricular septal rupture, essentially, with a big left to right shunt. That's this is again from another source. It's not my pictures. And this is sort of a weird one that I thought was kind of nice. Something weird's happening there. What view are we looking at?
Parasternal long and parasternal short at the aortic view level. Is it a sinus of Walisundara?
I think so. Yeah. Well, they just said it was like an aneurysm associated with the this is a perimembranous VSD and with a sort of aneurysm over there, and with the color. Whoopsies.
I think it's more common in the Asian population.
Oh, right. Okay.
Maybe Macabella.
And like there was a toe picture associated with this, and it was showing that it was actually causing right ventricular inflow obstruction as well. So it was like going into the tricuspid valve. Again, I think it'd be pretty rare to see something like this, but I thought it was cool. I'll just add at the end of this. And then finally, just some pretty 3D echo picture. So this is like in terms of further evaluating the VSD, you can put down the 3D probe and get a reasonably more accurate idea of what the size of the VSD is. So that's the VSD there. I think that's me all done.
Is Sam coming to do questions?
He said he had a family meeting, so maybe not be able to.
Yeah.
So I guess to summarize, like echo can be quite useful in evaluating this VSD, used to identify the location of the VSD, the size, direction of the shunt. Are there any sort of right-sided complications associated with the VSD, and how significant the VSD, hemodynamically significant the VSD? And that then sort of feeds to, do they need treatment, like, or like what kind of treatment they need at that time? Is it something that is relevant for us, or is something that can be managed in the outpatient community? And that's all from me, folks.
Thanks, Dash.
Any questions? And I'll probably defer to Emma.
Can I ask you a question?
Yeah.
So I've been trying to. I've not scanned a person with a VSD, and I've been trying to get my head around what are the best views to put a continuous wave Doppler probe through to try and calculate RV pressures and that sort of thing. And from what I can try and work out, conceptualizing it, it's going to be basically parasternal, probably short and long, and you're probably going to get a good Doppler angle on anything other than that. Is that right?
Yeah, I would say those were the best two, Ben. Maybe subcostal as well.
Yeah, right, okay. With anything that's going to be from the apical point, you're just going to be really perpendicular to flow, and it'll be useless, yeah. Okay.
Also off-axis apical imaging as well, depending on where it is, might be helpful.
Yeah, okay, cool.
Yeah, that's something I struggle with. Like whenever, if for ASDs as well, if I'm trying to get a Doppler, a continuous wave Doppler through that shunt, it's really hard not to cross another structure, and then I don't know if I'm getting a bit of like regurg and like what it, because it's just one continuous wave, right? So I find that to be the hardest part of the assessment. So I just usually just go off a visual color. Maybe I'm just a bit lazy.
I guess for your American exams though coming up, Ben, they do love to ask those sorts of questions. So.
Yeah, no, that's why I'm asking you guys.
They'll show you pictures of that for sure, I think.
Yeah, that's what I was expecting, and the standard hemodynamic calculations that derive from that. Yeah.
Fun. Okay, something to look forward to. Alrighty then, well, I might stop the recording, I guess, and then thank you, everyone.
Thanks, guys.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.